Hello everyone, and welcome to today's webinar, Let's Talk Supported Decision Making in Healthcare. Today's session has been designed for health professionals, and we're delighted to be collaborating with staff from across various hospital and health services in Queensland. I'll introduce our speakers shortly. We really appreciate their valuable contributions to today's session. So I'd like to officially begin by acknowledging the traditional custodians of the lands across Queensland on which we are all gathered today. We pay our respects to elders past, present and emerging, extend that respect to any Aboriginal and Torres Strait Islander guests joining us today, and we honour our First Nations people we support. My name is Rachel Meehan. I'm the Community Education and Engagement Officer here at the Office of the Public Guardian. I'm delighted to introduce our special guest speakers, Deidre Venz, the Program Lead for Queensland Health's QCAT Guardianship Program. This is a statewide service supporting QCAT hearings, guardian consultations, and supporting education initiatives for Queensland health professionals. Deidre has 25 years of social work experience and a keen interest in working with older people facing complex issues, including guardianship and elder abuse. From Metro North, we have Lihini Godakanda Arachchi, an advanced speech pathologist with extensive experience supporting people with disabilities. Lihini currently works in the Behavioural Escalation Response Team, also known as BET. And we also have Madeleine Brough, an advanced social worker working in BERT with Lihini. Maddie focuses on complex care needs and consumer advocacy. Joining us from the regions is Kamal Mustafayev. Kamal is a senior social worker based in St George and provides services across emergency, inpatient and outpatient settings in rural and regional communities. And also joining us is Dr. Lisa Kelly, I think zooming in from Adelaide. She's an experienced geriatrician working across not only Metro South, but Southwest Hospital and Health Services as well. Lisa specialises in dementia care from younger onset to advanced stages. Welcome, everyone. So today we're going to be talking about supported decision-making, its role in empowering people with impaired decision-making ability to make their own health choices, and its human rights significance. You'll watch a video featuring Melissa and her mother Helen, highlighting why supported decision-making is important. Our expert panel will then share how they use supported decision-making with patients with cognitive impairments. And finally, we'll answer your questions and guide you to additional resources. So let's now talk about why supported decision-making is so important. Australia is a signatory to the UN Convention on the Rights of Persons with Disabilities, and that sets out for us some expectations that we as a signatory will hold and apply. This includes people's rights to make their own decisions, regardless of whether they have any sort of disability or diagnosis. The Disability Royal Commission also recommended a rights-based framework, including the presumption that everyone has capacity to make decisions regarding their will, preferences and rights, and that there is a conceptual shift away from substitute decision-making to supported decision-making whenever possible, which Deidre is going to discuss with you in more detail. So what is supported decision-making? Well, it's about empowering individuals to make their own decisions and actively participate in decisions about their life and care. It focuses on providing tailored support based on a person's needs rather than questioning their capacity. This ensures they're always included in the decision-making process and can make choices that reflect their own views, preferences, and circumstances. So before we practically apply supported decision-making, it's important to understand its core principles. Firstly, start with the belief that everyone can make their own decisions. Most people may just need information or support in the right way. Support, don't substitute. The supporter's role isn't to make decisions for the person, but to support the person to understand what their options are, to help them consider the possibilities and allow them to express what they want. Next is respect what matters most to them. Use their values, preferences and goals to guide the process. It's not about doing what we think is best. It's about what the person is hoping to achieve and supporting them to do that. Then balancing the dignity and risk, explaining the risks and consequences, but avoid taking control. A risky choice isn't the same as a wrong choice, but it might have implications. The supporter's role is to help the person understand those consequences and what that might mean for them. And lastly, but most importantly, be flexible. Every person needs different support in different ways because every decision is different. It's important that the support you offer them is the support that they wish to receive, and it's how they wish to receive it. It's also important that they choose the support person with regards to that particular decision. So on screen are some steps which outline the process which we go through when making a decision. Many of us do this subconsciously. By defining each step helps everyone involved to offer the right level of assistance while respecting the person's independence and control. It's important to remember that this process can vary in time depending on the decision being made. It's also not a straightforward process. You might jump from step 1 to step 3 and then back to step 1 again. Support can come from a variety of people, including family, friends, carers, health professionals. And as we'll hear from our panel later, this support might involve putting the person at ease and making them feel comfortable, providing information that's accessible and easy to understand, helping them weigh up the options, risks and consequences, and allowing them time and the space they need to process the thoughts and express their preferences. So decision-making, when we think about decision-making, it's a person-centered approach that each of us could be on this spectrum at any particular day, depending on the circumstances and the decision to be made. At one end of the continuum is independent decision-making, where we make our own decisions, possibly seeking advice, such as buying a car or maybe a complex health matter. But at the end of the day, we retain full autonomy to make the final decision. Supporting independent decision-making wherever possible upholds a person's dignity and rights. At the other end of the spectrum is substitute decision-making, where someone else stands in the person's shoes and makes a decision on their behalf because they cannot do so even with support. Substitute decision-making, including guardianship, should always be a last resort and used only when other options have been exhausted. Even then, it must respect the person's rights and preferences, involving them as much as possible to ensure that their wishes remain central. The public guardian plays a critical role in safeguarding adults by promoting and protecting their human rights, and they may only be appointed as a substitute decision maker by the Queensland Civil and Administrative Tribunal, also known as QCAT. This is when a person cannot make decisions for themselves, even with support, and there is no one in their support network willing or suitable to act as their guardian. While this may be necessary in some cases to protect the person's well-being, it's a very restrictive option as it removes their legal right to make their own decisions. So wherever possible, the public guardian delegate guardians work closely with their clients to understand and honour their views, wishes and preferences. Only when these are unclear or pose a risk will the guardian consult the person's support network or make a substitute decision as a last resort. Now I'm going to hand over to Deidre from Queensland Health's QCAT Guardianship Program. Deidre will explore the elements of the current Queensland Government legislation, including the general and healthcare principles and other decision-making arrangements that may need to be considered. Thanks, Deidre.
Thanks, Rachel. So as Rachel said, I'm going to start off with exploring the concepts around the general principles and the healthcare principles with you, just to further the conversation. So within Queensland, there's specific legislation that underpins, such as the Queensland Guardianship and Administration Act and the Queensland Powers of Attorney Act as well, along with the National Disability Insurance Scheme Act and the Aged Care Act. There's a lot of acts there that align with the UN Convention, and these laws uphold a person's right to autonomy and decision making. So within Queensland law, there is those general and healthcare principles to support adults, including those who may face challenges in decision making. And these principles are really around treating everyone with respect and valuing their independence and supporting individuals to make their own decisions as well, listening to the person's wishes, respecting their culture and beliefs and protecting their privacy. And if anyone is needing help to make decisions, support should be provided in a way that respects their rights and freedoms as much as possible. So you'll see the 10 general principles there that are outlined that really help to underpin, I guess, the way that somebody would be supporting that person and bearing these 10 general principles in mind. Could we go to next slide, please? So further to that, we also have the healthcare principles as well. And so you'll see here that there's 4 different reference to the healthcare principles, and this is very much where, in conjunction with the general principles as well, these healthcare principles provide that further legislated framework for people who are providing that functional power when it comes to supporting an adult with decision making. And these healthcare principles, as the name suggests, specifically speaks to healthcare decisions. So the healthcare principles really ensure that all people who require a healthcare decision are afforded the same rights as anyone else. And the first step for applying these general healthcare principles is essentially to apply the general principles that we just looked at. And secondly, further to that, it's also about ensuring that the person who you're supporting or might be making a decision for have the same access to human rights and fundamental freedoms that anyone else might have access to as well. And this might involve, preventative care or further ensuring that there's no discrimination in applying this. Further to that, then, the third healthcare principle, which looks at performance of functions and exercise of powers, is also there to provide further guidance and relates back to general principles 9 and 10 to ensure that when a healthcare decision is required, that it follows elements that can help to weigh up making that healthcare decision. And this might be around ensuring that information is provided by the adult's healthcare provider. That might include the adult's medical condition, prognosis, awareness of other available treatment options, and then further to this, also deciding if healthcare could be postponed because a better option might be available, say, for example, or there might be a more reasonable time to sort of make a healthcare decision as well. So there's a range of different things there that need to be considered, along with substituted judgment, which is the fourth healthcare principle, which really relates to providing the application of General Principle 10 to make sure that when an adult's views and wishes can't be obtained, that there's very much consideration of whether there might be an advanced health directive already in place or something else that might lend itself to understand what the adult's position might have been in that particular situation for that healthcare decision that's required. So the next slide is actually in regards to capacity and the presumption of capacity. So it's really important, and I think this is such a critical piece, that we always recall the presumption of capacity, and that relates to any adult over the age of 18 is presumed to have capacity unless it's rebutted. And in terms of understanding who can rebut capacity, that falls to QCAT or to the Supreme Court within Queensland as well. I think it's something that can often get lost when we're thinking about capacity and where concerns might arise in regards to capacity. So there is a capacity test as well, which includes 3 different elements that involve: does the patient fully understand the nature and effect of the decisions about the matter? Is the patient capable of making decisions freely and voluntarily, meaning that they're free of intimidation, pressure or influence? And can the patient communicate the decision in some way as well? So I guess when we're thinking about assessing capacity in healthcare, it's really important to think about, are you concerned about the adult's capacity to make decisions, and are you seeking a capacity assessment, and what that might look like and how that might even occur within health as well. So there are all really important elements to sort of consider, I guess, when we're thinking about a person who might present to hospital and there might be concerns that arise around that person's ability to make decisions. So we'll move on to the next slide. When we're thinking about capacity assessments, we do have the guide to capacity assessments that was part of the amendments to the Guardianship and Administration Act back in 2020. And there's 5 different principles that are outlined within this document that refer to numerous steps that we need to sort of consider when we're considering capacity. And again, you'll hear that number 1 is very much, again, the presumption of capacity. The second principle is in regards to capacity is decision specific and time specific as well, with number 3 indicating the necessity to provide the adult with support and information that they need to make and communicate decisions. The 4th principle is around assessing the adult's decision-making ability rather than the decision that they make. And I think that's a really important one, because often we are thinking about, I guess, is it a good decision from our perspective, or is it just it's a decision that we wouldn't make? And that's a really important distinction to make. And that kind of fits in then with the 5th principle as well, which is respecting the adult's dignity and privacy. It's really rare, I guess, when we're thinking about capacity for someone not to have capacity at all. And so, again, important to think about the person's ability to make decisions. And sometimes, I guess, if somebody is unconscious or they're not able to articulate the decisions because of being very, very unwell, then that might mean then that somebody needs to step in. But otherwise, we need to be thinking about capacity across the different domains of being decision decision specific, domain specific, and time specific as well, because capacity is not always permanent, it can fluctuate. And so again, really important to keep these things in mind, and it can be temporary depending on the person's illness, delirium, dementia or disability. And another example might be if somebody has dementia or a mental illness as well, and they may have capacity to make decisions at certain times, but not at others. If we're referring back to decision specific, then we're referring to the range and complexity of decisions where an adult can make for themselves. And that might be around a simple decision for a personal decision where they might be able to decide that they might want to live in a certain place, but they might not be able to decide where they, their ability to sell their house, which could be a more complex financial decision. So again, there's a range of different things to consider when we're thinking about decision making and capacity assessments as well, particularly in the health context. So we'll move to the next slide where we'll think about conceptual shifts in decision making. So I guess in applying the practice of decision making, it's really important to think about this in a healthcare setting, because it's meaning that we really need to move to a more contemporised way of these decision making concepts. And that means that we're moving from best interests or interest-based to rights-based. So the person's views, wishes and preferences are paramount. We're also thinking about substitute decision making and thinking more beyond that to supported decision making where possible as well. And then mental incapacity, we're moving to the presumption of capacity again, and that's the third time that that's been referenced here. So you'll really get to hear that this is such an important presumption, and it's thinking about the decision making ability. The final conceptual shift that we're identifying here is around global incapacity and decision making ability, and shifting to decision specific capacity and ability. So next slide. When we move towards this, we're also thinking about decision-making hierarchy, because within health, it's really important to think about the decision-making hierarchy that might exist. And that might mean that we're thinking about what documents do they already have in place. So that might be that there's an advanced health directive, which would be the first port of call and would obviously speak directly to the adults' views and wishes in regards to their healthcare. It may be that there's a guardian appointed by the Queensland Civil and Administrative Tribunal, and that would trump an attorney appointed under an invalid enduring power of attorney document. Or it may be that we fall to, if there's none of those documents in existence, considering who might be the most relevant statutory health attorney as well. And you'll see the list there within that in terms of who is order of priority for who is readily available and culturally appropriate to exercise power for that particular matter. And we'll go to the next slide. So I think in healthcare, the other thing that comes up sometimes is a little bit of confusion around next of kin versus decision making. So whilst we're thinking about supported decision making today and the decision making hierarchy, there's sometimes some uncertainty in healthcare around the role of next of kin versus decision making. And next of kin is not a legally recognised role. But it's more when a person is admitted and they're often asked by administration, who is your next of kin? So I was thinking about who that might be for the adult. And this might be the spokesperson for the adult around what is happening for them whilst they're in hospital. It might even be that they're the person who, as a colleague recently said to me, who's feeding the patient's cat or watering their plants, but they're not the decision maker in the event that the patient is unable to make a decision themselves. We'll move to the next slide. So when guardianship might be needed as last resort, it's really important, as Rachel mentioned earlier, that there might be times when guardianship is required, but this again is only as a last resort and in keeping with least restrictive. And from a medical perspective, there are times when a person presents to health where there are those red flags that include patients who are unable to engage with significant decisions, and there are no other substitute decision arrangements in place that we referred to before, such as an AHD, EPOA, etc. Or there may not be a statutory health attorney who's willing or able to make a decision. So if QCAT appointed guardian might be able to support with informal supports, they're unable to come to an agreement and that's placing the adult at risk, then it may be that you then need to move to substitute decision making. But obviously you still very much need to keep in mind the adult's views and wishes at all times as well. So I'm going to hand over to Maddie now, who's going to introduce the video that we'll also be seeing today. Thanks, Maddie.
Thanks, Deirdre. So the following video was filmed with a Queensland Health consumer, Mel, her mother, Helen, and one of our team speech pathologists. When I was talking to Helen and Mel about the use of this video today, they wondered if their story was important enough to share. The hesitation shows just how deeply a lack of support and meaningful engagement can disempower families and make them feel invisible. But their story matters immensely. For this family, ensuring Mel's voice is heard is everything. She's clever and funny and has a lot to say, as you'll see in the video. When she's not communicated with, it feels like the world doesn't value who she is, and they're overlooking the irreplaceable role she plays in her family and her community. Mel is a perfect example, in my opinion, of supported decision-making, not just being a framework, but it being about dignity, respect, and belonging.
Melissa and Helen here. Thank you for joining us. Now, Melissa, you're our consumer with lived experience of disability, and I want to thank you for volunteering your time, and you too, Helen, as Melissa's mother, to talk about supported decision making and what that looks like for you. Now, my first question for you, Melissa, is I know you like to be involved in decisions about your life. Have there been times that health professionals haven't asked you what you want? Can you remember some times that that might have happened, or things they didn't ask you?
Melissa.
Is that a tricky word? Can I check? We've got new. Are you trying to say a tricky word like nuisance, or something different? Is it nuisance or something different? Nuisance. Are you saying that you feel like a nuisance to healthcare practitioners? Why do you feel like that?
Melissa, disability.
Because you have a disability. Yeah. So you feel like you're a nuisance to health practitioners because you have a disability. Okay, thank you for sharing that. Now, Helen, have you observed any occasions where health practitioners didn't ask Melissa what she wanted or what her choices were?
Never.
Never? No? Are you always there when Melissa presents to hospital?
Yes, not 24 hours a day, but
Yeah. Yeah, and so you found that health practitioners are usually pretty good at asking Melissa what she wants rather than directing questions at you?
No, they don't ask what Melissa what she wants.
Okay, so what does that look like? Is it that all questions are directed towards you and people don't think to ask Melissa, or what do you think's happening there?
I think a lot of the time people don't ask me either. They just come and do whatever they need to do at the time. I think one of the failings is that with people who don't speak is that they don't explain what they're about to do. So someone comes walking up to you with some kind of instrument and they don't say, oh, I'm here to take your blood pressure or, whatever. They just do things to you. Which is very frightening for people when they're in hospital. But I don't remember anyone ever saying to me, is it all right if I do blah blah or whatever?
Sure. But so whilst they're certainly not always asking you, they're never asking Melissa what she wants or if something's okay. Yeah, okay. And I know for you, Helen and Melissa, there is a formal decision-making arrangement in place, so the QCAT arrangement, which appoints you and Melissa's dad as her decision makers. What does that formal arrangement look like within your family? How do you sort of treat that arrangement when it comes to decisions?
Well, Well, we always obviously try to think what's best for Melissa. Sometimes decisions can be really, really difficult. For example, I've told you about, the decision to put a peg, and that was a really, really hard decision to make. And I'm still to this day think, did I make the right decision?
Sure.
It's a huge responsibility to make a decision for somebody else and what the ramifications of that might be.
And do you find that, because I've noticed, I guess, watching you interact, that you are always checking in with Melissa, asking her preferences, what she would like, where it's possible. Do you find that makes it easier as a decision maker if you know what Melissa's preferences are?
Yes, I guess after over 50 years, I know what Melissa wants, so I don't really have to ask her.
Do you think if someone else was appointed as a decision maker, that they would have those skills as a family member?
No.
What would be your worry there?
Well, even with her sister, she's been away from home for 30 years or something. So I think that you have to live with a person to know what what they want, what they don't like, what they do like. And I think, yes, I don't think people really think about it, particularly in a hospital, about, I wonder if this person really wants me to do blah blah, or, can I explain what I'm doing and why?
So let me ask you, Melissa, how does your mum Helen involve you in decisions about your life?
Talk.
She talks to you. Yeah. And I think that's something I've really seen, is that mum talks to you like she would talk to anyone else, right? And she asks you questions. And do you feel that mum listens when you say what you want and what you don't want? Yeah. Do you think everybody listens? No, not everyone's a great listener, are they? It's different, isn't it? So, if I ask you, Melissa, how can health practitioners involve you in decisions about your care and your life?
Talk.
They can ask you and talk to you.
I can't have my life without it because I try to talk.
So, my next question's for Mum, is that alright? Okay. So, Helen, what are your expectations as a family member and decision maker for health professionals supporting Melissa's decision?
I can only go by the advice that they give me, and then I have to decide for myself what's best for Melissa here. We've had a lot of, I suppose, dramatic times with dramatic decisions to be made, and it's very tricky when it comes to anything medical.
Absolutely.
Because obviously the first thing any mother wants to do is to care for her child and have them safe and well. And with someone with quite a few disabilities, you often can't, it's hard to just be the normal sort of decision-making mother, because you're making decisions for an adult person, and which you never really thought you would ever have to be doing. So I still make decisions with that Melissa doesn't agree with, I can assure you, because she's constantly aiming for the sky.
But I suppose you're always making decisions with Melissa in mind, where you can keep her preferences that she's indicated as part of that decision. You absolutely do.
Oh yes.
Are there do you have any advice for health professionals who might work with Melissa or people like Melissa around how they can support decision making, both for Melissa and for families and decision makers?
Well, if we're talking about nursing staff, that's one thing, and we're talking about medical doctors, that's another area. I've found that nursing staff in general are pretty good. Most introduce themselves, and I think if they would just perhaps explain a little bit about what they're about to do would be helpful. Doctors, that's a different story. Because they don't know what's going on, and they don't know what to do, and they don't know what to suggest. And I guess when someone, a young doctor particularly, the last time she went to hospital, they've sort of never come across someone like Melissa with multiple disabilities, and they don't know just how to approach this, or so they talk to you, they don't talk to Melissa, they talk to you.
And Melissa's very capable of telling people what she thinks, aren't you?
But I think in a hospital situation that's a different dynamic, because you know, she's there and she doesn't want to be there, and she can't really, you know, she has no power when she's in hospital. Things are done to you. So yes, we've had, it's actually strange, because I think doctors really need some training in how to speak to families and you know, special needs people. And we often, maybe I'm just paranoid, but I sometimes think they think, well, why bother? You know, this is not worth. So you get that impression from doctors that, okay, some people aren't really worth their time.
So probably your lived experience as a family with disability is that you don't feel that maybe you're given the same consideration as other patients in the hospital. And I guess it would be tricky, and correct me if I'm wrong, it would be really tricky to be a decision maker and make these big tricky decisions if you feel you're not getting all the information, because already making a decision for someone else is a complex thing. So I can imagine if you feel you haven't got all the information, that's even harder to do. So sometimes would it be fair to say that appointed decision makers might need more conversations and more discussion and more involvement to help them make good decisions about someone's life? Yeah. Well, that's really helpful. Melissa, is there any tips that you want to give any of the nurses, doctors or health professionals about how they can work with people with communication differences and disabilities? Any hot tips?
Teach them more.
We need to teach them more. Yeah? Do we need to teach them more how to communicate with people with disability? Yeah? Now I'm going to say some things and I want you to nod if you think that they're helpful, because these are things I tell people to do. Is it helpful when people go slow? Yeah. Is it helpful when people give you lots of time to say what you need to say? Yeah, I thought so. Is it helpful when you've got mum or someone who knows how you communicate there to help you? Yeah. Finally, is it important when you've got your device so you can tell people? That's right, because there's been times where you haven't had your device, have you? Really tricky to tell people when you haven't got your communication tool. All right. Is there anything final from you,
That's
Helen?
probably something that people don't realise, that she actually can communicate. Maybe that's, you know, a bad thing in the process of just sort of giving that information out to staff so that they know that.
Absolutely. Yeah, and that's our job, I guess, to get it written down and make sure if you've got a communication device that it's there and it's charged. It's really tricky to use if you haven't even got it with you, right? Well, I'll thank you again for your time. We might pause it there. Is that okay?
It's really some really powerful messages there from Melissa and Helen, and we thank them very much for giving us permission for us to share it with you today. They were very keen for us to do so, so we do appreciate it. Okay, let's meet our panel members now. I am actually going to start with you, Lihini, if that's okay. My first question for you, and you've previously told me that you're obviously we know you're a dedicated speech pathologist with strong passion for person-centered practice, supported decision-making, and empowering your consumers by promoting communication and autonomy. So, Lihini, why is supported decision-making so important for individuals with impaired decision-making ability, particularly those with communication challenges?
Thanks, Rachel. When I think about supported decision-making, I just think communication. So as a speech pathologist working in the disability sector, I often see communication difficulties mistaken for a lack of capacity, which can prevent people from participating meaningfully in decisions that affect their lives. And many of the people I support face barriers to understanding information, expressing their preferences, and communicating their choices. So one of my key roles as a speech pathologist, and I think all speech pathologists, is to help people overcome these barriers by identifying how they understand and express information and what supports they need to have their voice heard. We also provide strategies to carers, support workers, and other health professionals so that they can communicate more effectively with the individual. And that's why I think it's so important to include speech pathologists as part of the multidisciplinary team. We help to ensure that communication difficulties are not mistaken for a lack of capacity and that people are given genuine opportunities to participate in decisions about their own lives. When communication barriers aren't recognised or appropriately supported, the impacts can be significant. This can be particularly evident when a person displays behaviours of concern. So communication difficulties and behaviours of concern can sometimes lead others to make assumptions about a person's capacity to make decisions. When someone's communication is not well understood, their attempts to express their preferences, refuse options, or communicate discomfort may be overlooked or misinterpreted. Behaviour often serves as a communicative function. It can be a way of expressing an unmet need, exercising choice, or communicating that something is just not working for that person. And as speech pathologists, our role is to understand the message behind the behaviour and support more effective ways for that person to communicate their needs, preferences, and choices. At its core, supported decision-making is about ensuring people have the right supports in place to express themselves and participate in decisions that affect their lives. It also recognises that everyone has the right to make choices, regardless of the level of support they may require. So for people with communication difficulties, we tailor supports to ensure they can still participate in these decisions. These supports might include easy read resources, visual supports, the use of communication devices like Mel's that you saw in the video earlier, or using that individual's preferred method for communication. It's also super helpful to provide extra time for processing or involve a trusted support person like Helen in the video that we saw earlier. And when people are supported to participate in these decisions about their lives, I believe the outcomes are better because these decisions are more likely to reflect what is genuinely important to that person. It promotes choice, control, self-determination, and quality of life, while ensuring that the services we provide remain truly person-centred. A recent example of mine that demonstrates what supported decision-making can look like in practice involved a young non-speaking gentleman who moved into a new supported independent living home with an entirely new support team. The staff wanted to support him to engage in meaningful activities, but didn't know his interests or preferences, so he spent much of his day at home on his iPad. To support his involvement in this decision-making, I used Talking Mats, which is a visual communication framework that helps people express their views and preferences using pictures and a simple rating system. This process allowed us to hear directly from him, rather than relying on others to make assumptions about what he might enjoy. From this, we were able to develop a weekly schedule based on his interests and preferences. And as a result, he had more opportunities to participate in activities he enjoyed, build relationships with his new support team, and experience greater choice and control in his daily life, all of which improved his quality of life. And for me, this example captures what supported decision-making is really about. It's not about making decisions for someone. It's about providing the right support so they can make their own decisions to the greatest extent possible. Ultimately, it ensures that decisions reflect what matters to the person and keeps their rights, preferences, and autonomy at the centre of the process. It helps us move away from asking what's easiest to asking what does this person want and how can we support them to tell us.
That's a great message. Thanks, Lihini, and excellent example. So thank you for sharing that. Madeleine, I might move to you next because you work with Lihini and the BERT team in Metro North. Why is supported decision-making essential in your experience in complex care situations?
Thanks, Rachel. So when I think about why supported decision-making is essential in my work, it really comes back to that fundamental principle that people should be involved in decisions about their own lives wherever possible. So in healthcare, particularly when working with people with disability, it's easy for decisions to be made around a person rather than with them, as we saw in the video with Mel. Supported decision-making challenges that approach and ensures that a person's views, preferences, and goals remain central to their care. As Lihini said, we often talk about complex or challenging behaviours as a form of communication, and when we engage people appropriately in the way she mentioned, we often see a reduction in distress and escalations. This has significant benefits, not only for the individual, but for the healthcare system. It can reduce length of stays, reduce the need for restrictive practices, improve safety for both the person and staff, and create more positive experiences in healthcare. One example I commonly encounter is when there are competing priorities between what a healthcare team recommends and what a person wants. Often this comes down to the time required to support someone to understand a procedure or healthcare process. In our team's experience, investing time up front through social stories and other communication strategies Lihini's mentioned in an accessible format, it's always worthwhile. So it may require that upfront time, but it often saves time in the long run. So when people understand what is happening when they're involved and they know what to expect, we generally see less anxiety, less distress, and they're more able to participate in their care rather than responding to distress once it's occurred. We want to proactively support people's understanding, predictability, and their choice. I often ask healthcare workers to consider this. So imagine you are lying in a hospital bed and unable to speak. How would you want people to respond to you? Would you still expect staff to talk to you, explain what they're doing, and involve you in decisions about your care? And I think most of us would say yes. But what usually happens is conversations happen around individuals rather than with them. Staff speak to families, as we saw in the video, or support workers, and they unintentionally exclude the person at the centre. Supported decision-making reminds us that communication is not limited to speech. Our role is to identify what supports a person needs to understand information, express preferences, and participate in decisions about their own life. It's also important to remember that supported decision making is not only about major healthcare decisions, it's about the everyday decisions that we take for granted. So what we wear, what we eat, who supports us, when we shower, or how we receive healthcare. A lot of those are taken away from us when we're in a healthcare setting as well. So giving people some of that choice and control back and allowing them to be involved in those decisions. They build autonomy, confidence, and self-determination, and we should support them at every opportunity. A common assumption I get is that it's easier to move straight to substitute decision-making or guardianship processes. In reality, it's actually a much lengthier process, and it's really stressful for families and patients and often results in delays. And if we've engaged in supported decision-making, if we do need to go to substitute decision-making, we've got a more robust evidence-based as to why it's required, and we're looking at the true rights of the person that we're working with. So I often encourage teams to consider all of the strategies Lihini has already mentioned, so easy read and other ways to communicate with people differently. Sometimes with the right adjustments, people can make decisions that others initially assumed they could not. And if they genuinely cannot, again, we have more evidence to go to guardianship or use those more restrictive practices, but they should always be a last resort. Obviously, recognising as well, family members and supporters like Helen play such a huge role, and they genuinely want to know and honour the wishes of the person that they support, but they often don't know how to facilitate that. So sometimes that's where us as healthcare workers come in to help with that. And one of the most rewarding parts of the work that we do is helping families find ways to better understand the communication attempts of the person so that their voice can be heard. We often underestimate people's ability based on if they're non-speaking in particular. When assumptions are made too quickly, it can impact not only their healthcare engagement, but also a person's sense of identity and confidence, as you saw with Mel, with her thinking that she's a nuisance to the healthcare system. There is absolutely a place for safeguarding, guardianship, and protective measures when people are vulnerable and at risk. However, even when formal orders are in place, supported decision-making should never stop. There are always decisions that people can be supported to make, and when we stop looking for these opportunities, we risk unintentionally reducing people's skills, confidence, and independence. Ultimately, supported decision-making is not about balancing care needs against a person's preferences. It's about finding ways to provide safe and effective care while ensuring the person's voice remains at the centre of every decision. That is what genuine person-centred care looks like.
Thanks, Maddie. Kamal, we might move to you next. My question for you, because you're coming from to us from St. George, you offer, therefore, a unique perspective on supported decision-making in resource-limited areas. So for you, Kamal, why is supported decision-making particularly important in rural and remote communities?
Thanks, Rachel. I think that one of the really important facts that we have to consider is that supported decision-making requires for us to explore context. We have to consider those context-specific considerations. In rural and remote circumstances, I think in a general speaking that we have a limited access to medical services. We have limited access to service provision with NDIS, medical, my aged care services, and transport options. And a lot of the time that when we talk about healthcare decisions, they are very often intertwined with personal and lifestyle decisions together. However, that element is often overlooked when we are making those decisions and telling patients about those decisions. So I think that as a clinician, we have to consider those broader life impact and not just clinical needs when we are making healthcare specific decisions. In rural and remote settings, I guess a lot of treatment are not necessarily available depending on where you are, such as, dialysis, chemotherapy, radiation therapy, infusions, or even imaging. So that often requires a lot of traveling involved for the patient to navigate different health services, navigate different hospitals, and then sometimes even relocation to a larger center so they can receive ongoing care for that specific treatment. And those decisions not only involve yes and no, I do want this treatment, also involves yes, where do I want to live from this point onwards, who I'm going to live with from this point onwards, and then taking patients away from their usual support and community. That also adds challenges when patients has cognitive impairment, and navigating, I guess, what we normally take as granted, like public transport, will be really tricky for people traveling to metro areas. On top of that, we also have to unpack what the impact of this to the carers and families, how many times they have to take time off to take the patient to a larger center to attend those appointments. So I think as a clinician that we have to unpack those impact to support them to make informed decisions. One of the, I guess, most common decision that we see in hospital is aged care placements. And in metro area that you probably have 6, 7 different different aged care facilities within 2 or 3 suburbs in south of Brisbane. But when you're looking at remote and rural area, that there are very limited aged care options available, meaning that a lot of the time that they probably have to relocate to a different town if they don't have aged care facility where they live, or if the existing aged care facility is not suitable to cater to the level of care the patient needs, meaning that they have to relocate to another town or center where they are able to access dementia-specific units, memory support units, to be able to find a place where they can be looked after. That means that they will be losing the community connection, losing the support that they have, place that they have lived for years, people that they have known for years, that will be removed. For First Nation, I guess that also means that there's a risk of leaving the country where they're connected to culturally because that they don't have access to where they are living. For people on rural and remote property, I guess we don't normally see this because they own the same suburb, but unfortunately that if you're looking at places where people have to travel 40 minutes to access aged care services for just someone to be showered 3 times a week, that's a huge ask. From a clinical point of view, I think clinicians probably should explore all these different options for them when they are making those healthcare decisions. What would that look like for them with a real life implication of every decision they make? What would that look like for their own circumstances? Understand their values and preferences to say, what would that look like for you if you do make these healthcare decisions? And support decision making in practice, it will definitely involve us to break down all of those complex decisions and then align those options with patient preferences and then the likes. I think as clinicians that we have a responsibility to have those honest and open conversation about the healthcare with patients and their families. And then we want to support the patients to explore different options and what would that mean for them in their own circumstances so they can consider those decisions. And I think that in the video that we see, Helen mentioned that it was really hard to make decisions for someone else and that she wasn't sure if she was making the right decisions. And we do see them a lot in substitute decision making. And actually, this reflects how important it is for us to consider advanced care planning processes as a way of capturing patients' likes and preferences when they are not actually in crisis. I think ACP is critical as a guide or a handbook for patient support network and can also be a conversation starting point. ACP also provide those, I guess, choice and control for the patient and also act as a reassurance and clarity for the decision makers as well as healthcare professionals.
Thanks, Kamal. Some really excellent points there. Lisa, your focus is on balancing clinical care with patient autonomy, particularly those with cognitive impairments. So why do you believe supported decision-making is so important in dementia care?
So following on from Kamal, I think across the journey in dementia that there's various points where it's really, really important that we plan for the future. We document what people's what's important to them and what they value in the earlier stages where we're doing advanced care planning, when people keep capacity, try to have powers of attorneys, but also a statement of choices and really getting them to have conversations with their families and to document what their values are. As Kamal mentioned, in rural areas, that might be, I don't want to fly out. So it might be a very specific thing. But then as we go along the journey and people gradually lose capacity or the ability to communicate, we need to reflect and talk to their support people and work out what is appropriate for this person, but always talking to them in that as well. And the next real transition moment can be when somebody's going into residential care and we reflect on how appropriate that is, and if whether they agree or not, but also more healthcare planning at that stage about what their newer goals are around their healthcare, especially with regarding coming back to hospital. So it's really, I think in dementia, it's not a single point. It's really encouraging their conversations with their substitute decision making. And if you can do that at an early point in the journey, it actually makes everything a lot easier for the people around them to provide appropriate care. So always asking, you know, what matters to you? What matters to this person? Even in very late stage dementia, people can tell you that what matters to them is time with their families. It might be seeing their dog, it might be something small, but that's really important that you try your best to support what people do. And I suppose the final point then is on a simpler clinical level, even if people can't communicate, there's implied capacity for procedures, for medications, and people can be very clear with their behaviour as to whether they want a procedure or not. And we have to really take that into consideration as well, and trying to be as least restrictive as possible and to provide appropriate care.
Thank you. Excellent. I don't know if you guys can see the screen, but you have generated a lot of clapping and hearts.
Yes.
So I think the points that you've made have resonated with our audience. So thank you so much for your contributions. We might move to the questions and answers. Oh, actually, no, sorry, Deidre, over to you. You can sum up.
Oh, thanks, Rachel. I know we're getting pushed for time.
We are,
but I guess we've had a lot today around supported decision making. We've also had the honour of second in practice with Mel and Helen. So I think in summing up from a health perspective, it's just really important to take on board the learning opportunities today and really thinking about those conceptual shifts that we talked about earlier as well. And when we're working with patients in healthcare, the absolute importance of including the patient, finding out how they communicate, what adjustments are needed, and making those reasonable attempts that might be visuals, easy read options, or monitoring behaviour. It's also important to consider how to best deliver the information to patients and their supports as well. So thinking about, you know, how can we ensure that there's a quiet room, or it might be that we have to redeliver the information more than once, or it could be that we're writing it down. So we're looking at what those different options might be. And as Lihini and Maddie also talked to as well, the importance of slowing down, which is certainly not evident in me right now. But I mean, when we're talking to patients and families, it's so critical that we do slow down, because cognitive processing can be impacted by stress. The other really important thing to note as well is around considering advocates as well. And that might be internally linking with social work, but it also might be externally linking with other advocacy services as well, such as ADA or QAI. It's really about all up making sure that within healthcare, when we're navigating different decisions that might be required, that the right supporters are present and that there's that opportunity for collaborative planning. So I'll hand back to you, Rachel, now.
Thanks, Deidre. So this is everyone's chance now to ask some questions, and I see we've already got a few in our Q&A chat. Just a reminder, we're using the Q&A button that's on the top of the menu bars to engage. So I'll start with the first one, which has come from Mark. And this might be for you, Dr. Kelly, but feel free, everyone, to chime in. I frequently come across treatment authority when the doctor has deemed that the patient does not have insight into their condition and therefore they are unable to make decisions about their treatment and care. Is this always a valid statement, and shouldn't it be time limited?
So I didn't catch the start. Was that about mental health treatment authorities?
It frequently come across treatment authority.
Yeah, I suppose I won't comment on mental health. That's got a very strict guidelines and checks and balances where there is always, and it's a legal document which is very separate to what we do. I think in dementia, it's always more nuanced than that, even if people don't have insight, because people do lose insight in dementia. We have to really give time, and we have to deliver the information and try and build that insight. And if we can't, then sometimes we do need to engage the QCAP process. But we're always very clear that we've gone through every step possible and given people sufficient time, given them the information. So an example might be somebody who doesn't want to go to a nursing home. but they're not able to walk. They're needing 2 people to provide care, and they don't have the finances to have that care in another setting. So we have to, in that case, eventually we do have to get an external decision maker involved if we can't build capacity or go along the journey together. I think, yep.
Yeah. Does anyone else have anything to add to that, panel members? Kamal?
Yeah, I guess I just want to add it on briefly. I guess within that mental health, they're going through a specific act, which is Mental Health Act, and within that, they have mental health tribunal who's going to oversee some of those treatment authorities and provide advocacy as required. So there'll be psychiatrists in that process to manage, but as well as we've got case managers to taking on likes and preferences and then considering the psychosocial holistic care of this patient and present to the tribunal in that way.
Fantastic. Thank you. You're absolutely right. All right, moving on. What is the best way for community providers to liaise with hospital during admission for a capacity assessment? What is the best way for community providers to liaise with hospital during admissions for a capacity assessment?
I can start with that one. I think it's going to depend. It's going to depend hospital by hospital, service by service. The first question you're always going to be asked is capacity for what? We will only do any type of capacity assessment if there's a decision to be made. So I think that's going back to first principles. If there isn't a pending decision to be made at that time, you'll really struggle to get somebody in a hospital in an acute setting to be calling complex capacity unless it directly impacts on the discharge plans. So I think what's probably more important is to be able to have good transfer of information. It's the same person who goes across community to hospital, back out to community again. And how do we all have the same information? I think it is often the issue we have in hospital, that we don't have all the information when we're planning things. Did you want to take that as well, Kamal?
I think Lihini might want to. Oh, sorry, Kamal.
Sorry. Yeah.
And then we'll move to Lihini.
Yeah, I would agree. I guess as a social worker, I would say social work is probably a really good contact as to build a bridge between healthcare services as well as the family and patients. So, but sometimes Indigenous liaison officers, multicultural officers are also a good way to build that bridge.
I think another good thing to note is that sometimes you might feel like someone doesn't have capacity, but how they present in hospital can be quite different. And also if the person doesn't want us to talk to you or share information, we also can't. So that's a consideration as well. Even if we have done assessments, we may not be able to communicate that with you. I think one thing that's often missed is people think that in hospital things can just get fixed. Particularly those long-term deteriorations and things, it's better managed in the community with ongoing support from outpatient geriatricians, GPs, things like that, where they can build a picture of someone. But I think the important part of this training in particular is the person's choice and control. So if they're saying, and we think that they can make that decision not to share information with you as a provider, we can't.
Thank you. So in relation to patients requiring interventions like PIVC insertion or, oh goodness, phlebotomy, sorry, I'm not medical, that causes pain and a patient with dementia says no. Does a clinical accept this refusal even though a family member may have differing views to the patient?
I take it that's for me.
Thanks, Lisa.
Well, first of all, it depends. It depends on what our advanced care plans say. If we've got an SHA, if we've got an EPOA. But I would be having a serious conversation saying, you know, this is clearly distressing the person that you're meant to be supporting their decisions for. We need to have a discussion about what our limits of care are. And that, you know, if you can, you might not always change things the first time you do a cannula, but I think if it's clearly distressing somebody, our staff are told not to keep going with things like that. We don't want to physically and chemically restrain people for interventions that they clearly don't want to. but it's always a conversation. There's no 100% right or wrong answers on these, but I would be definitely talking to the substitute decision maker and talking about whether this is something we should still be doing or not, because you don't just do those interventions once, you do them over and over again. So, you know, with people who don't want to take medication, and you have SHA saying, give them the medication. So I can restrain them day one, but it'll be the same issue every single day. And they're implicitly telling me that they don't want these interventions. And on very rare occasions, again, we have to get QCAD as an independent person, where we feel that the person isn't making decisions that's in the best interests of their loved ones. And we deliberately go and ask for an independent third person because we might be wrong as well.
Lihini, you'd like to add to that?
Yeah, I was just going to say, often in my experience, I've seen when people are declining or refusing services, there may be a little bit of a communication breakdown. So it's really helpful to review how we're communicating, what's going to happen and the why behind things. Because like I mentioned earlier, behaviour is a communication. So if someone is confused about what's happening, they're going to be hesitant, they're going to decline. So let's communicate what we're doing really clearly, and hopefully that helps as well.
Also, don't lie to people. Don't say a blood test isn't going to hurt. It does.
Yeah.
Then you're a liar. They're never going to trust you again.
Yeah, that's really important, that, you know, to encourage consumer autonomy, it's to generate that trust, isn't it? Okay, this one's quite long, so bear with me. This may be too unique and specific, but in our community services, we have had a couple of cases where clients are deteriorating in the home and declining our staff's request to escalate to QAS. We have challenges in determining the client's capacity to consent when they are acutely unwell, as we don't have medical governance in our services to determine capacity. It makes us a little stuck in terms of escalating. Any suggestions for assessing capacity to be able to decline QAS in acutely unwell community dwellers?
I'll just say that if someone's acutely unwell and you're calling ambulance services, that's actually up to the ambulance officers to determine if that person can make the decision to go to hospital or not. It's not up to you as a service provider. That then falls on QAS. They're the ones that make that call.
Thanks, Maddie. I'm just going to ask one more, and then in the interest of time, we'll have to take a record of all of the questions that are coming in, and thank you so much for those. This one is, I had a patient who was under guardianship for accommodation and service provision. MDT's recommendation has been a nursing home placement for a long time. He was deemed to have capacity around health decisions. He wanted to discharge against medical advice, which falls under health decisions, and return home. In his case, can he leave the hospital and return home? And if he's open to getting nursing input in the home, will this service fall under health decisions or service decisions?
So service decisions in the home would be service provider decisions. That's not a healthcare decision, that's service provision. In terms of people making a decision for them to discharge against medical advice, and Dr. Kelly can probably speak to this more, but they have to be able to understand the risks of returning to the environment that they're going to. So he's been able to demonstrate he understands that it's risky, and he's chosen to do that anyway. So the hospital can't prevent him from leaving.
Lisa, did you want to add anything to that one before we move on?
I would agree. I think you might also have a situation where there wasn't a pending healthcare decision to be made, so no one's been appointed for that, because it sounds like the question was on service provision and accommodation, and healthcare wasn't included, so QCAT wouldn't have a role, and it's just a reflection of the increasing complexity in this area, that we sometimes have to go back and have another decision about healthcare. But yeah, it sounds like he was judged to have capacity to leave the hospital. So it's in a bit of a grey area. And we equally then should not be keeping him against his will if he has the capacity to do so.
Yeah, thank you. Thanks, everyone. And we will take your questions on notice, and we'll ask our panel to reply, and we'll send the details out in the post-webinar email for you. So I'm going to move on to wrapping up now. We've made some clear points today. Some of them are here on the screen. Everyone has the right to participate in making decisions about the things that impact them. Decision making is a continuum. A person can move up and down this spectrum depending on the decision that is being made. Substitute decision making is considered the last resort and only when the adult cannot make a decision even with support. And to help guide you, OPG and Queensland Health have a range of resources available on our website. This is how you get to it. So you can either click on the QR code there or on the link. And you can also stay up to date with OPG news and events via our website, via LinkedIn. And we also have a YouTube channel where recordings of these webinars are uploaded along with other explainer videos. So that's it for today. Thank you so much for joining us. We do appreciate the level of engagement we've had. We hope you found today's session very informative and beneficial. We've got a link there to a feedback survey and we'll send it out in the post-webinar email as well. It only takes a couple of minutes and we'd really love to hear from you. I'd like to extend a very, very special thank you to our guest speakers today, Lihini, Maddie, Lisa and Kamal, and especially to Deidre, who has helped us gather everyone together. Your contributions have been invaluable and we couldn't have made this session as we did today without your help. So thank you very much. Everyone, our contact details are now on the screen there. So if you've got any further questions or inquiries, please don't hesitate to send us an email and we will happily reply. So thanks again. We hope you enjoy the rest of your afternoon. Bye, everyone.